We would like to acknowledge the traditional custodians of the land on which this podcast is produced, the Whadjuk Noongar people, and pay our respects to their elders, past, present and emerging.
Welcome back to another episode of the podcast. How are you doing, Courtney?
I'm good. How are you?
Yeah, not too bad.
Excellent.
Nice sunny day here in Perth.
Yeah, and it's winter.
Yeah, it was pretty cold.
Sunny. Yeah. Well, I mean,
this morning anyway.
This morning was cold. I'm sure it'll be lovely in the middle of the day.
Yep. We seem to get rain on a few days and very heavy, and then nice crisp sunny days in between.
Yeah, I'm sure it's like summer for other people though.
Yeah, I speak to family in the UK and they sort of say it's 20 degrees here. It's a lovely summer day, and I'm like 20 degrees
I would
in
be
Perth
in like
as well.
Yeah, jackets and scarves and stuff.
Yeah, but we're not here to talk about the weather.
No.
We're here to talk about Associate Professor Jennifer Stone.
And her work in breast cancer.
That's right.
Obviously is a very important topic. And I think breast cancer, there's a lot of health promotion and a lot of information out there, particularly here in Australia, because it is one of the most well-known cancers.
Most prevalent as well.
Most prevalent, and also has quite a high mortality rate.
I think so. Certain types in particular.
It has a lot of bad outcomes. That's the big one. Yeah.
And it seems quite treatable if it's detected.
Yes.
If people
there's
find it early enough.
There's lots of opportunity with breast cancer to stop it.
So Jennifer's involved in looking at a range of things, as you'll hear in the conversation, but particularly the genetic component of breast cancer. Which we go into in quite a bit of detail. And she has a bit of an interesting story about her journey in academia and coming from Canada and whatnot.
Yeah,
where she's been. So we'll let her tell you a bit more about that. So I'd like to welcome Associate Professor Jennifer Stone to the podcast.
Thank you very much.
Thanks for joining us.
Thank you for having me.
See, the way we usually do this, for people who don't know you, we usually get guests just to give us a bit of background about their education and kind of their journey through to where they are, and then kind of what they're currently doing.
Well, you might be able to tell from my accent, I'm Canadian. Mm-hmm. So I started out at the University of Guelph, thought I wanted to be an engineer. But then quickly discovered what engineering was and decided I preferred the maths and statistics.
Yeah.
And so I got a master's degree in statistics and got my first job at the Ontario Cancer Institute in Toronto, working with Norman Boyd, who's the father of mammographic density research. Unbeknownst to me, I had no idea at that time that he was sort of directing the rest of my career. And after 3 years with Norman, he suggested I consider a PhD. And I said, how about Australia? Because I'd previously come to Australia for about a month to work with Professor John Hopper at the University of Melbourne to do this twin analysis, which ended up published in the New England Journal of Medicine, which again, at the time, I had no idea the severity of that
Always
publication. It was
how significant that is.
Yeah, and so then I went to University of Melbourne, got my PhD. I was there for about 10 years before moving to Perth just about 8 years ago here. So.
And what brought you to Perth?
So my husband,
I feel like you've been paid to say that.
Well, it was funny because I'm a National Breast Cancer Foundation fellow. I was at the time as well, so I'm quite transferable. His job, of course, he's an accountant and moved us across. And I was like, well, what am I going to do in Perth? And turns out there's quite a bit for me to do in University of Western Australia. It's been tremendous. It's been a really good experience. I think word got out that I was arriving, and then so all the research community and the clinical community also just sort of embraced my arrival. And I met up with some key stakeholders, and we established this program of research, and we've just been working through it. Okay. So it's really exciting stuff.
And so where do you sit these days, and what do you do?
So I'm currently head of the genetic epidemiology group here within the School of Population and Global Health. I lead a team of genetic epidemiologists, statisticians, a handful of students, and all working across various different diseases, everything from breast cancer to sleep apnea.
Yeah, okay. And you guys recently came to the school, fairly recently, like in the last year or so, right?
Yeah, we moved just before COVID.
Yep. Great timing.
Yes, it was. We were formerly the Centre of Genetic Origins of Health and Disease, and we made the strategic decision to move from the School of Biomedical Science. When we were in that centre, it was a lot more molecular, the sort of stuff that was doing, but what was left of the group, we were really more involved in the epidemiology and the data analysis, and we don't pipette anything.
Okay. So you guys primarily are using linked data, administrative data, and investigating that?
Lots of linked data, lots of health data, but also I'm responsible for the TIBS breast density study, which is transillumination breast spectroscopy. We collaborate quite a bit with the RAIN study, for instance, and so to generate actual participant data, obtain the measurements of women, their mothers, grandmothers through the RAIN study. We did a crowd research recruitment process through UWA crowd research, which was fantastic. It was amazing, the impact, I guess, of social media, where one woman's response, she did something on Facebook, say, hey, look, this is what I just did today. Everyone should, sign up. And overnight, we got 164 women.
Oh, wow.
Contact
really
us and want to be a part of the study. So, yeah, we do actual recruitment of real life people, not just crunching numbers.
Yeah, that's really interesting. Yeah. So I don't know a lot about genetic epidemiology. And I don't know about you, Courtney. But
no.
So
no, not at all.
What is it exactly, and how do we use it to understand illnesses and diseases?
Well, epidemiology, of course, is the sort of study of disease, very simply. Genetic epidemiology is the using genetics to find associations with disease. So you have sort of the simplest case, I guess, where you are found to have a genetic mutation and you have the associated disease. There are other instances where you have a genetic mutation and you have an increased risk of developing the disease, but not necessarily Mendelian, yes or no. Then you have several examples where you could have a combination of multiple hundreds of genetic variants that combined contribute to an increased likelihood of developing a disease, and that's when you start talking about things like polygenic risk scores. So, and then of course you have combinations of genetic variants that interact with environments and lifestyle factors and things like that, and that increases your likelihood of disease. And then of course you got a whole branch of like epigenetics, which are genes that are switched on, switched off, depending on, again, their environment. So that's just sort of a very brief breakdown of the sort of where, I won't go into the genomics and the other omics and stuff, but
So the epigenetics side of things, is that where people talk about nature versus nurture? There's some nurture things which can trigger certain things to happen.
Yeah, I thought that epigenetics was just basically genetic research. I thought it was just like the general term for it. So obviously I'm wrong.
No, it's a whole other branch of research, which is not my expertise at all.
Yeah, no, that's fine.
Recognizing that there is that sort of area where, it's how the gene sort of is turned on and off. Through either methylation or a whole bunch of other ways that
proteins and stuff.
Yes.
Okay. Interesting. Yeah, that's really fascinating. And what are some brief examples of diseases that we currently use genetic epidemiology to investigate and find out more about?
All sorts, but
like all of them, right?
Yes.
Except for maybe don't know about infections, but
I suspect that there's some that are probably focused on more at the moment than others, right?
Well, obviously the ones that have been shown to be heritable, right? So where you can do before we were genotyping the genome and stuff, we still could do twin studies and use relatedness to establish whether or not there was a heritable component or a familial component. So a lot of cancers are highly heritable, and like I said, my research in particular deals with breast cancer, which where there's the common BRCA1 and BRCA2 genes. That would be an example of where you have the gene. If you're found to have being carrying a mutation, then you'd be at increased risk of the disease. Similarly, but thankfully, the BRCA1 and BRCA2 genetic mutations are quite rare, and that's why a lot of the research is also looking at hundreds of these other quite common genetic mutations that each individually are not strongly associated or increase or explain a lot of the variation in breast cancer, but in combination you could potentially identify women who are at increased risk. And that's sort of where that's where I come in. So the idea is to identify women at increased risk, either due to genetics or their environmental factors or breast density, more particularly, which is a lot of the work I do, to I guess, personalize and tailor their sort of screening approach so that you can find the cancer sooner and thereby reduce mortality significantly.
Okay.
So, I feel like the genetic component of breast cancer, I know that I've heard it in like health promotion kind of stuff for general public, and I feel like it's one of the few areas where genetics is known by the general population to influence cancer. But I have no idea about breast density. So I've heard the genetics, but I haven't heard the breast density bit. So how does that influence breast cancer?
So breast density is are you familiar with a mammogram?
Yes.
So a
That's
mammogram
where they
is
squish your boob.
Yes,
Yeah.
it is. So it's an X-ray of the breast.
Yeah.
And when you look at an X-ray, you've got white areas and dark areas. The white areas represent the fibroglandular tissue, the epithelial and stromal tissue, as opposed to the dark areas, it's fatty tissue. So it's the opposite of fatty tissue. And the more white areas you have in a mammogram, the more, for your age, the higher risk you are at developing breast cancer.
Right.
Okay. And if you do it, so this fibroglandular tissue increases the propensity for tumors to develop, but also because tumors are white, dense tissue is white, it also makes it very hard to detect them.
Right.
So it's a bit of a double whammy.
Yeah.
Right.
Okay. All right. So
Okay.
white is bad.
However, white is bad, but all women have breast density of some sort. Okay, it's incredibly common, and it decreases with age. So that might seem a bit counterintuitive, because of course your breast cancer risk increases with age, and that's because I guess the true risk factor is your breast density for your age.
Okay.
So genetically, so we know that breast density is highly heritable. So again, when the breasts develop in puberty, women will start out with very different levels of breast density, even at very early ages. But the majority of women will have very dense breasts, and then as you go along, depending on your number of kids you have and other hormonal exposures, breastfeeding, all these factors that have been shown to be associated with breast density are also associated. They're also risk factors for breast cancer. So it's a sort of like a mediating factor. So yeah, the density decreases over time. It's also highly correlated over time. So if you have dense breasts for your age at 50, chances are you're going to have dense breasts for your age at 65. Okay, but recognizing that if a woman was to go to have a mammogram at age 40 and be told that she has dense breast, she's joining a very large club. Lots of 40-year-old women will have dense breasts, and that's one of the contributing reasons for why mammography is not necessarily recommended for women. It's free. Mammography is free for all women in Australia aged 40 and above through the breast screen programs. You're not actively targeted until you turn age 50.
Okay.
So that's done through the electoral roll, and they can identify, on your 50th birthday, you'll get a letter in the mail saying, come get a mammogram.
Happy birthday. You're getting your breast x-rayed.
So yes, it's very, very common. It's one of those factors where, yes, okay, lots of women have breast density. Not all women are going to get breast cancer.
Yeah.
It's just about recognizing your risk factors. That's when taking into account all these other risk factors, either your polygenic risk scores, your family history, and then trying to identify, well, what's the best screening recommendation for women with your risk factors.
Yeah, because it's not uncommon for women under those ages to get breast cancer if they're unlucky.
Yes, unfortunately, women under the age of 50, lots of them do get breast cancer.
Yeah.
The idea, I guess, the challenge is to balance out at what age do you start screening all women to find those few women who are, and so it's definitely a delicate balancing act.
Yeah, obviously.
And there's currently no screening recommendations for women with dense breasts. So if you can, lots of women into some of the consumer advocacy work that I've done, women generally want to know about their breast density, but yet from a health professional perspective, it's quite difficult to talk to them about their risk factors because, well, there's no evidence-based screening recommendations for women
with
dense breasts. It is.
So the advice seems to be to individuals to check their breast density for changes, right?
Absolutely. Be breast aware.
Right.
So know, be familiar with your breasts. Lots of women have very lumpy breasts, and just to be aware of any changes, just like you said. You cannot tell your breast density by feel or touch. However, it's a mammographic phenomenon. Just because your breasts feel hard or soft, it doesn't matter. It's not actually indicative of what your breast density is.
That seems to be the theme with cancers generally, like skin cancer, testicular cancer, is about changes. So you're told to sort of check for changes in things, aren't you? Yeah.
Yeah.
Okay. And I've heard a little bit about breast cancer. It's one of those things that touches almost everyone in society in some way. We all know somebody, whether it's family or friends or whatnot, who's experienced it. You hear about different types of cancer and some being particularly aggressive and whatnot. What can you tell us about those differences?
So there's different subtypes that like ER positive, ER negative, HER2, triple negative, and as you said, some are more aggressive than others. The literature describing the association between breast density and those subtypes is a bit inconclusive, and basically saying that breast density is a risk factor for all of those subtypes.
Right.
So doesn't seem to be any kind of definitive evidence about causing one or any other. However, breast density is strongly associated with developing an interval cancer. So that's a cancer that was not detected at screening. So all women age 50 to 74 in Australia are recommended to get biennial screening. That's every 2 years. Women with family history are recommended to get annual screening. However, if a woman attends that screening mammogram and then gets the all clear, your routine results letter says, no presence of breast cancer, but then within the 24 months before your next due for your mammogram, whether even a woman finds something either by touch or feel or some other incidental test that she's had, then that's called an interval cancer.
Right. Is that the same as pre-cancer?
No, it is a full-blown cancer.
Yeah, okay.
It just wasn't detected. It was detected in the interval, and it wasn't detected at screening.
Yep.
Now, unsurprisingly, a lot of those that are interval cancers that didn't get detected were in women who had dense breast, because there's two ways. It could have been the cancer was there and it wasn't seen, or it's a really fast-growing that suddenly emerged just after a mammogram. So both are referred to as interval cancers. So women who have very dense breasts are 17 times more likely to develop an interval cancer. And because those interval cancers are not detected and they're sort of later staged and sometimes also have more aggressive tumor biology, they have much poorer prognosis.
Right, okay.
So a lot of my research is trying to identify women who are at increased risk of developing an interval cancer.
And that's because of the sensitivity and the specificity of the screening that we currently have.
Absolutely.
Right.
The sensitivity of mammography is usually above 90%. In women with dense breasts, it's around 60.
Wow.
Right.
So
okay.
Breast Screen WA is the only state currently that notifies women if they have dense breasts.
Yeah.
Just informing them about the reduced sensitivity of mammography.
Okay. And so screening is a process, is not exactly diagnosing, is it? So screening would sort of indicate that there's an issue, and then would you then go for a biopsy or something else?
That's a very interesting question. As I said before, there's currently no evidence-based screening recommendations for women with dense breasts. Okay, so right now the recommendations are to consult your GP.
Right.
Okay, so to engage a conversation with your GP, have a clinical breast examination, have a conversation about your breast health, then the GP are provided information about what to be, how to manage their patients, to consider their other risk factors in combination with breast density, and if they do have obviously any kind of breast symptoms or anything like that, but a family history as well, to then maybe consider supplemental screening, either through ultrasound, tomosynthesis, MRI, but the problem with supplemental screening is, of course, that they're also prone to quite a lot of false positives, ultrasound in particular. So by recommending that additional tests at the woman's own cost, up until this stage, mammography is free. Right. You attend your GP and refer for supplemental screening. There will be a fee associated with that. There is a rebate, but there's still costs involved. And then a lot of, if they do find something, that's when you have breast biopsies, more surgeries, more different procedures that could inevitably show nothing in the end.
Yeah,
so
it increases stress and cost and all that kind of stuff, and no real reason for.
And yes, in otherwise well women. So, like I said, the breast density is quite common. They estimate that 43% of all screen-age women have heterogeneously or extremely dense breasts. Now, that's almost half the population of screen-age women. Okay, so if all those women were referred for ultrasounds,
oh my god,
that'd be
huge waiting lines.
And just the costs involved in that. For at what benefit? Now, the more tests you do, the more cancers you will find. Yes,
of course.
And for ultrasound, it's for every extra 10,000, you'll find 4 extra cancers. So that's a lot of ultrasounds.
Yeah, a lot of extra tests.
However, as an individual woman,
if you're one of those,
I'm one of those 4, I'm like, thank you very much. So it's really, as an epidemiologist versus as a woman, it's often quite competing messaging.
That is that balancing thing that we all learn about in epidemiology. With screening things and what age groups are most at risk. So is the cost justified and that sort of thing. Yeah, it's very complicated.
Yeah, we definitely learn about like cost effectiveness and all that kind of stuff just to make sure we get the whole population, but not spend too much, but not save too many people, but also save enough people. It's a big balancing act.
So obviously there's a lot of work ongoing in this space, and you and your team are involved in that. What do we know so far about risk factors for people for breast cancer?
What are the other risk factors?
A lot of the risk factors are sort of I guess around your cumulative exposure. Okay, so and this is in addition to genetics. Okay, so we talked about the genetics. We know about some of those. There's still quite a bit of work to do in that space. Then there's, from the, age at menarche and age at menopause are both, you want to decrease essentially the time in which you are cycling. So a later age of menarche, when you start your periods, is associated with a reduced risk of breast cancer. Earlier age at menopause is associated with, so the more kids you have at earlier ages, and the more you breastfeed, there's other hormones, replacement therapy, for instance, has been shown to increase your breast cancer risk. It increases your breast density as well.
Yep.
And they've shown that's also a sort of a temporary association. If you stop the HRT, hormone replacement therapy, your breast density will go back to normal, and as will your risk. So then there's the opposite. Tamoxifen, for instance, is a very common drug to prevent recurrence in women who have had a certain subtype of breast cancer. They've also shown that if tamoxifen will, in healthy, high-risk women, can reduce your breast cancer risk, and it's been shown it reduces your breast density. So breast density is arguably modifiable, right? So if you reduce your breast density by a significant amount, then you can reduce your breast cancer risk quite substantially. The problem is that tamoxifen has quite a few associated side effects, and that it's not a proper solution.
Yeah.
You don't want to take it as a preventative.
Well, it is recommended by some, depending on the medical oncologist, depending on your risks, and depending on whether you have these associated.
If you're in a high-risk group, it might be worth the
and if you can put up with the side effects.
Interesting.
So just to clarify on, so you talked about obviously years of menstruation, essentially, like when you start and when you finish, and also having children. How are those things related to your risk of cancer?
So, again, I'm a statistician, Craig. Have we talked about?
I guess the main question is that the more kids you have increases the risk of cancer or decreases?
Decreases.
Right.
Yes.
So we should have more kids.
You should have more kids and at earlier ages.
Right.
Yes.
Okay. And then starting menstruation at an older age, and then finishing, and then going through menopause at a younger age
is protective.
Is protective as well. Okay. So,
but these are not things anyone can really control, really.
No.
Like, really.
No. But they do.
I'm just going to stop my menstruating for a year, thanks. All right.
They do sort of, I guess, give you a bit of guidance into what category of risk you might fall into based on when you've gone through them, right?
Yeah.
Yes, but those are not very common risk factors. We don't measure those when you attend screening. We focus on the big ones like family history, whether or not women are on HRT, ovarian cancer history as well. And like I said, I think in future, assuming it would be great if we could also have a genetic test to test, because the polygenic risk scores are designed to capture genetic mutations in a lot of genes across that are very common. So you're not screening for a BRCA1 or BRCA2 mutation kind of thing, which are quite rare. You'd be screening for all these combinations of genetic variants. You use that in addition to their family history and stuff that we're already collecting, height and weight information, which only, again, in Breast Screen WA is the only state that does that, and then your breast density. I think then you'd have quite a bit of power to be able to categorize women into different categories of risk. And then the question is, so if you're at high risk and you're at low risk, what are the recommendations that need to be
implemented for that person?
Exactly.
Yeah. What should apply? This is a bit of a simple question, really. How do we collect genetic information on people?
So you can, obviously you can collect a blood sample, but also you could use a buccal swab from the inside of your cheek, use a saliva sample. So they're getting more advanced in how you can do these things. Then there's sort of, if you're doing that on a population level as part of a screening program, you have issues about privacy, ethics, storage, maintenance and logistics. So those are some real practical issues that also need to be addressed.
Yeah. And I guess a fairly high profile example of this type of knowledge being put into practice, I remember a few years ago, Angelina Jolie had a double mastectomy. She had never been diagnosed with breast cancer, is my understanding, but she did have one of these genes that you're talking about.
Yes, and she had a very strong family history.
Right.
Yes, so it's a fairly invasive decision. It was a very high profile case, and she opted for a double mastectomy. Again, it's a challenge to know what screening recommendations. I think MRI is typically the modality of choice for BRCA1 or BRCA2 holders or carriers. So it's
lots of options. I feel I wonder what the ongoing effects of that particular case was. Was there an increase in breast removal or something like that? I reckon there probably would be if it was a celebrity that did that.
Well, there was the Kylie effect for mammographic screening. So when Kylie was diagnosed, the breast screen programs across the country saw a huge influx, particularly from younger women.
Yeah, interesting.
And would you say that's a good thing to come out of an event like that, or would you say that maybe there wasn't too much value in that happening?
Well, participation in screening is vital for to work.
Yeah.
So yes, I would think increased participation in screening is desperately needed, particularly in some demographics as well, culturally and linguistically diverse or Aboriginal and Torres Strait Islander women. I mean, the latter in particular, very low participation, but yet have incredibly high mortality rates. So yes, I think in terms of messaging and public health messaging, I would encourage all women, particularly in the targeted age group between age 50 and 74, to attend breast cancer screening. Breast screening is an amazing program. Younger women, it'd be aged between 40 and 49. If you have a strong family history, or it is free for all those women.
Okay.
And just to be breast aware. If you have any concerns or any symptoms whatsoever, obviously make an appointment, just consult your GP and get that sorted out.
Is there a reason why the age group is 50 to 74? Why does it finish at 74? Just out of interest.
So it was previously 69 up until 2014, I think. They did some evidence-based analyses to show that there's still benefit in screening women longer. And I think that it's 69 and 74 is because that's when you would stop getting invited to rescreen.
Okay.
Right? Because you come every 2 years, so you stop getting your invitations to come.
And there's probably some sort of like life expectancy issue there as well, because everyone's getting older, and the survival's getting longer. So I can see that is one of the reasons why it might increase.
Well, I'm just wondering why it finishes at 74 was more my question. Why is it not 80 or...
the benefit, they've presumably the analysis would show that the benefits once you reach a certain age. Also, your risk, if you get to a certain age and you haven't developed breast cancer, then your lifetime risk of developing breast cancer is pretty low.
It does diminish,
right? Yes.
Once at a certain point.
So
and then also, like, if you get breast cancer at 80, or it's like detected at 80, that doesn't, like, the amount of life gained by going through those surgeries might not be worth it at that point. So that, like, there's the weird, like, balance there. But because everyone is living longer, they've increased a lot of those things, I think.
I think it's the same with any major procedure, like people getting hips and knees and stuff replaced. Once you hit a certain age, your chances of recovering and your chances of contracting an infection and whatnot make it not really that worthwhile.
Well, the point of screening is for early detection to promote,
and at 80
to reduce
years old,
mortality
it's not really
and
early anymore.
And going through chemo at 80 probably is...
that sounds horrible.
So you mentioned there, so you sort of touched on social determinants a little bit with the types of groups that might experience poorer outcomes in this area. So who are the messages aimed at from policymakers?
Well, obviously improving life expectancy in the lives of Aboriginal and Torres Strait Islander women is a huge aspect of breast screen's priorities. And also increasing participation in culturally and linguistically diverse women. I think the main message is to improve the participation rate so that we can so there's quite a bit of work that goes on in that space. It's actually really, really impressive. Breast Screen has research officers that specifically try and target and to improve participation. Western Australia is a massive country geographically, so they have mobile vans, for instance, that will 3 of them that go around all year, and to make sure that even women in remote parts of Western Australia have access. That's a huge issue, again, accessing for women living in very remote areas to have access to the screening. So it's a well-oiled machine to try and, but still, it's difficult, I think, particularly for women who then, if they do have a mammogram and require further assessment, giving access to those services is also a challenge. So there's lots of challenges to be dealt with regularly, and Western Australia is not helped by its very large size.
Yeah, I mean, people living on the edge of the Gibson Desert and, you know, in the East Kimberley and whatnot, I can imagine there's a lot of remote communities that are not large communities, but obviously half of the population presumably are women, and a certain percentage of those are going to be in these, you know, age groups, aren't they?
Yeah, and again, they have Breast Green has an Aboriginal project officer, and then again, the idea is to sort of go into these communities and do like large group bookings. So and to make sure that, you know, there's interpreters and community workers there to sort of support that community, and make sure that they go back there every 2 years.
Yeah.
So it's pretty incredible.
Yeah, it's interesting. I've sort of did a little bit of reading of your profile, and I noticed that the consumer involvement is quite a big part of what you do. Do you just want to tell us a little bit about that?
Yeah, well, wow. So I had this amazing experience, about 6 years ago now. So I organized a consumer consultation, organized through the WA Community and Consumer
Health Research Network. Yes,
that sounds about right.
Yeah,
I think they have a different name now.
They do. I think it's called Involving Consumers or something. They're the ones at Telethon Kids Institute, right?
Yes.
Yeah.
But also, you know, affiliated here with the school.
They also have someone who comes in here.
Absolutely. Yeah. And they were fantastic. So they helped me identify 8 women and we sat around a table to just sort of assess the knowledge and awareness of breast density and what they knew, and the idea, the research question was to develop a survey of all women who attend Breast Screen WA. And so we needed to come up with sort of identify the research domains that we wanted to target. Mm-hmm. And like I said, it was incredibly eye-opening. So we had some women who, you know, who were like, oh, I have really large breasts, I must have dense breasts. Oh, I've got really small breasts, mine must be dense. So one woman who received the dense breast notification letter from Breast Screen WA and said, oh, I saw that letter, and I chucked it in the bin. And another woman who's sort of like, I didn't get a letter, should I get a letter? Yeah. You know, like it was another woman, you know, who've gone through breast cancer and, you know, to share their experiences. And other women who are sort of like, well, not all women can afford ultrasound, not all women have access to ultrasound, you know. So it was just absolutely brilliant. And so that then formulated these research domains in which we developed into the questionnaire, and then we, through more and more consumer engagement, that we, I'm also sit on the Breast Screen Consumer Advisory Council as well, which is an amazing group of ladies who they essentially review all materials that are distributed to any breast screen participants. And so we administered this survey, and I don't know about you, but I get requested to use surveys every other day and promptly hit delete. We got over 7,000 women, just under 7,000 women, respond to our survey in less than 6 months.
That's great.
That had about a 23% response rate, which I think is tremendous.
Solid,
we were hoping for 10. And that has just been an amazing body of evidence to help inform breast screen policy, here, not just in WA, but nationally as well. Mm-hmm. And yes, women want to know their breast density. Mm-hmm. They do feel informed by knowing their breast density, but there is, 20% of women did identify as feeling anxious about their breast density. Mm-hmm. But a lot of those women also had combinations of risk factors, with strong family histories and so on and so forth. Other women, 20% of women also reported feeling confused, and I don't blame them. It's a very confusing thing. Yeah. So because you're told you have dense breasts, but then, okay, what do I do next?
Yeah.
And it's
Why do I need to know this information?
Yes, it's not a clean-cut response. No. So messaging is very difficult.
Yeah, because it really does put a lot of the burden, if you like, or the onus on the GPs, doesn't it? The way the messaging is.
Yes. So.
And I'm assuming not every GP is an expert in breast
Absolutely.
health. You know?
So Breast Screen does a great job. They try and they've got obviously lots of information on their website. They, every woman who attends, if they nominate their GP, a copy of their results letter also goes to their GP along with some information. If they're told if dense breast, they get additional information. They do run regular education sessions for GPs, and they have a GP liaison officer. So if they have any sort of questions. I'm also in the process of trying to write a grant application to engage GPs to assess their knowledge and awareness and what they do with that information, how they source the information and what they do with it, and hopefully identify some actionable areas where we could improve the information for GPs and help them do their thing. And back to the consumer thing as well, that work also then led us to start. We established, again, through the CCHRN, a national breast density consumer advisory council. So we have representation from every state. And we meet, we're supposed to meet face-to-face once a year, but COVID hasn't allowed that. But we have virtual meetings quarterly. And they've been absolutely, again, fantastic in terms of just this sort of consumer advocacy moment. Consumer advocacy in Australia, definitely in WA, I think is quite strong. Nothing on the scale of America and the United States, where they have the Are You Dense campaign. This was essentially established by one woman, Nancy Capello, although she was a force to be reckoned with. She's unfortunately no longer with us, but she was receiving routine mammography, got the all clear, and then before her next mammogram, found something, had it investigated, and sure enough, it was quite an aggressive and late stage tumor. And she looked at her doctors and sort of said, I've been doing everything right. How did this happen? And they're like, oh, well, it's not that surprising. You have dense breasts. And she was like, what do you mean I have dense breasts? No one told me I had dense breasts. And so then she single-handedly was responsible for the state of Connecticut changing their legislation so that all women, it's mandated now, all women must be notified of their breast density.
Wow.
So, and that has then resonated across the whole country, and 38 states have some form of legislation, and there's now national legislation. So the FDA is currently working on language so that it's consistent across the whole country, what to tell women about breast density.
And how does this work? What age are they, I guess, measured for their breast density?
Well, it's very different in the United States because it's private healthcare mostly. So any woman can go and get a mammogram at any age.
At any age, okay. And so you say it's been legislated that it's mandatory.
That if you have a mammogram,
okay,
they already have the infrastructure in place. They have a clinical assessment of breast density called BIRADS. It's 4 categories. The first category is mostly fat, then it's scattered density. Third category is heterogeneously dense, and the fourth category is extremely dense. Okay. And anyone who has the upper 2 categories, the heterogeneously or the extensively dense or extremely dense, are considered dense breasts, which is dichotomous, not ideal. Your breast density is it's on a spectrum, and so that's a whole other area. That's a lot of my research as well is trying to find the best way of measuring breast density. But so they have this clinical assessment, and that's part of routine mammography. There is for that assessment to be done. That infrastructure doesn't exist in Australia, so that's not naturally done. So to facilitate some form of breast density notification or reporting in Australia, that would have to be changed first. So there are now automated, FDA-approved software that will measure breast density using either these 4 categories or on a continuum. There's obviously a cost associated with that, but it is a reliable measurement that can be used. But again, then the next question is, what do you do with that information? Particularly on the spectrum, if I tell you that your breast density is 13, you'd be like, okay, sure, so what?
All right.
So some of the work that we're trying to do is put that into context. So your breast density is 13. That puts you on the X percentile for other women your age. And that's why it's very important to compare your density to other women your age, because, of course, it decreases with age. So that's, again, more research that we're also trying to delve into that space as well, to put it in context.
Yeah, interesting. Hi, we hope you're enjoying this episode of The Meaning of Health. Just a quick reminder that you can email us at meaningofhealth@outlook.com or tweet us at healthmeanswhat. And if you have a minute and you've enjoyed listening to this episode or any of the other episodes, it'd be great if you could go and rate and review us wherever you get your podcasts. It helps other people find us. Now back to the show. In Australia, have we adopted that classification system at all? Do you know?
No.
Okay.
It exists, right? But it's not recorded. So breast density is not recorded as a BI-RADS classification. Yeah. Even here in WA, it is it's almost like it's more dichotomous. It's a flag where a radiologist would flag a woman's screening assessment as being dense or not dense. Okay. And that flag then generates the information that would go into her routine results letter.
Right. Okay. So for West Australian women, it's a yes or no.
Yes.
And that's it. Yeah.
Okay. And what's your view on that with the knowledge you have? Do you think it's something that would be beneficial for us to think about?
I think there's obviously considerable room for improvement. Like imagine particularly with the risk prediction models, if we had a continuous variable, that would be much more powerful statistically in particular, that to be able to, but then you need thresholds, you need cutoff points saying, okay, if your density is above this level, then you should receive supplemental screening. Or if it's below this level and you've got no other risk factors, perhaps you don't need to be screened as often. Yeah. Right now we have this one size fits all. All women get screened every 2 years. So there's a lot of work to be done in the measurement side of things. Of course, with the introduction of AI-based methods. There's all sorts of going on. So that's the AI stuff is happening in the detection space, just to be able to do the job of a radiologist, essentially, right? Find a cancer.
And then possibly have that improved as well, particularly with dense breasts.
Well, what we're trying to do is trying to predict who's going to get cancer. So we're looking at mammograms, the mammograms before they were diagnosed.
Right.
Is there something in there that indicates, because that's what breast density does, right? It's been shown that breast density measured in mammograms can predict breast cancer 8 years later.
Right.
Okay. It's a continuous measure. It's not a yes, no, it's really
interesting. I'm curious, is it just a photographic kind of image that you're analysing, or is there other information collected during a mammogram?
So a mammogram is essentially a two-dimensional image of a three-dimensional object. But digital mammography is now allows volumetric measurements of breast density, and this commercially available software that I told you does a volumetric measure instead of a lot of the previous research has just been using an area-based measure. The AI stuff ignores density altogether. It's just using all the information there is in a mammogram, everything, to predict who's going to get cancer and who doesn't. So it's a combination of risk factors, a combination of this pixel and that texture and that that sort of thing. Because there is other sort of texture-based methods that said, well, is it really the amount of breast density or is it how it looks on the mammogram, right? So the issue with the AI-based measure, so I think in terms of risk prediction, risk stratification, personalized screening is, it'll be able to identify women at increased risk, but it doesn't solve the reduced sensitivity issue, which, and they're both, they're not mutually exclusive. They both, so the dense tissue increases the propensity for the tumors to develop, and it also prevents you from being able to see it. So if you have an AI-based measure that predicts risk, you don't actually know what it's doing. We can't do what's the biology of an AI-based measure, whereas we can study the biology of breast dense tissue to figure out what it is, why cancers develop in it, and also then trying to reduce it so that you can improve the sensitivity as well as reduce the likelihood of the tumors to develop.
So these things all get combined to run millions of processes to really work out what it is that's going on.
Yeah, so I think for the AI work, whether or not you're predicting screen-detected cancers or you're trying to detect interval cancers. And again, that's another thing. So that's how we, from an epidemiological design point, that's how we can differentiate the two areas.
I think it's a great example of where, because you know how like a lot of people argue that AI is going to take over all of our jobs and all that kind of stuff. I think it's a great example of where it really doesn't. It's complementary. It
needs to be guided, doesn't it?
It needs to be guided. Yeah. There's other information that needs to be known in order to put those processes in place continuously checked. Yeah,
absolutely. And there's also a lot of much more collaboration is needed between the AI's experts and the epidemiologists.
Yeah.
To give you sort of an example, there was a paper that showed that they could predict, not predict breast cancer, but detect cancers. Oh, I can't remember. Apologies. I'm going to get this all wrong. But they showed they have an AI-based measure that strongly predicts breast cancer risk. Let's pretend.
Yeah.
But they didn't adjust for age.
No.
So what their AI measure was actually doing was finding older people, because older people get cancer.
Yeah.
So
much higher risk.
Right?
Yeah, having that clinical input be like, hang on a second.
But they argue that you shouldn't have to, right? That you should just be able to use the information in a mammogram and predict who's going to get disease and who's not.
Yeah.
But it's
you can tell them we don't need a machine for that. I can tell you this person here is 20 years older is more likely.
More likely, yeah.
Yes, exactly. So if you're looking at the AUCs and things, it has to be improved from what you already know, not from baseline.
Yeah, absolutely.
Yeah, so we're probably getting towards the end of our conversation, Jennifer. But yeah, just in summary, it sounds like you're really involved in, the genetic side of things. You're involved in the messaging and the health promotion side of things, and also in detection.
The measurement,
the measurement. So it sounds like you've got a foot in all those camps. Yeah. Absolutely.
Like all of my research is just accumulating evidence to support the clinical use of breast density to improve breast cancer screening outcomes. Yes.
And what do you have happening at the moment and in the future? What have you got planned?
One thing we haven't talked about is we've recently just finished up I touched on it lightly, the transillumination breast spectroscopy, which we're changing the name because it's much more
calling mouthful.
Optical breast spectroscopy. Yeah. Okay, so this is a tool that is measuring breast density. It's not diagnostic in any way. It uses light. So it's like a cup is just sort of held over the breast for less than a minute. It shines lasers through and just measures breast tissue composition that way. Now, it's still a medical prototype. But it's exciting in terms of research because it allows us to look at not just black and white, but also breast tissue. And it's because it's completely safe, we can use it to measure breast density in younger women. So that's what we've done. We've found these women between 18 and 40, where these women are not eligible for mammography, so that we do not know anything about their breast density. There's been a couple of MRI studies. Our colleagues formerly from San Francisco, they've developed or adapted DEXA, which are usually measured bone density and body composition, to also measure breast density. So we have these OBS measures and these DEXA breast density measures on these young women. And the idea is, with a lot more future research, but first of all, to get an idea of what breast density looks like in younger women, but also trying to monitor change in breast density. And like I said before, that there's tamoxifen can reduce your breast density, so you could use this as a tool to see if the tamoxifen was working, and hopefully in future there'll be less invasive interventions that could, again, you could do a sort of a clinical trial and where some women get the treatment and some women don't, and then you monitor their breast density over time to see whether or not it has any effect. And ideally, you want to be doing that in younger women, not necessarily older women, because the sooner you intervene and the sooner you can reduce your breast density, then the less chance you have of developing, and the more chance you're going to have of seeing it if it does. Yeah. So we're just in the last stages of this study, in collaboration with the RAIN study. Thousands of women now with these measures and combinations of measures, and we're trying to identify the determinants of breast density in younger women, establish what the distribution is, come up with like an age centile approach, like I talked about what your breast density is for your age, the genetic variants, changes over time. So yeah, it's just hopefully it will inform a whole other area of research in younger women, which we know nothing about at this stage.
Yeah, it seems like a pretty obvious gap at the moment, doesn't it? Yeah, fascinating.
Yeah, very interesting.
Well, yeah, that's been a really great conversation. Hopefully it wasn't too painful for you.
No, it was surprisingly nice. Yeah,
good. Thank you very much for coming on.
Appreciate
it's been really
you
good.
making the time, and we look forward to hearing a bit more and seeing a bit more about what your group's doing in the future.
Thank you very much.
Thank you. And that was our conversation with Jennifer Stone.
Oh, that was good. I thoroughly enjoyed that conversation. I didn't realise that breast density was like a massive deal. I had no idea.
Yeah, it seems to be a complex kind of thing because it needs to be understood well, and patterns of breast density seem to differ and indicate different types of risk and whatnot. But
It's interesting. It'd be cool. Obviously, I'm not within the age group for screening yet, but it'd be cool if you actually got the images so you could actually have a look yourself. But I don't know whether I think that might just be my opinion. I would be interested in it. I'm not sure if everyone else would be.
Yeah, interesting to hear the different approach in America where people by law have to be told what their breast density is when they get measured.
That's very interesting.
So and the systems they've got in place for that.
Yeah, and that's probably fueled by like obviously all of the health stuff in the US is private and all this kind of stuff. So they'd have a lot of money going into the tech as well.
There's money is probably the single biggest difference in money and profit over there. Obviously, it's a profit-driven system, whereas ours is a public health type system. Medicare's universal.
Yeah, you got to provide it to everyone rather than the wealthy.
Yeah, and often where there's commercial incentives, that drives innovation and a desire to reduce costs and improve outcomes and whatnot.
So that must have happened.
Yeah, I think over time. Yeah. And as it is one of the major cancers, obviously they've put a lot of resources into it. And we have here as well.
Oh, absolutely.
It's just manifested differently. And it seems like WA might be leading the pack in how we manage it.
Well, hey, look at that.
Which I was really interested to hear how we handle some of the Indigenous people in the remote communities.
I didn't realise there was a van that drives around. That's really cool. Also, that would be a super fun job. Yeah. I think that would be, good.
I'm sure it's quite rewarding work.
Absolutely.
Being educators as well as providing a service, a medical service.
I do wonder how many people, what the uptake is for those vans.
It would be interesting to see some numbers. But I'm sure that work's being done.
It'd have to be, right?
I would put a bet on Jennifer somehow being involved in it.
Yeah.
She seems to be quite active in this space, as you heard, a few different areas that she's involved in. So, really interesting. I hope you guys enjoyed the conversation.
Yeah. I mean, I'm sure that we could talk about it for a while, but
we clearly did. As usual, you can contact us at meaningofhealth@outlook.com and tweet us
at health means what. So please contact us. We would love to hear from everyone. If you've got any ideas or just want to say hi.
If you enjoyed an episode or there's one we haven't done yet that you want to hear, please let us know. Thanks very much for listening, and we'll be back with you soon. The Meaning of Health podcast is produced with the support of the School of Population and Global Health and the Education Enhancement Unit at the University of Western Australia. The podcast is produced by Craig Cumming and Courtney Webber, with music by Craig Cumming.